Welcome to this week's version of the Medical Center Show. I'm Joe Scott, the President and CEO. We have with us one of our premier orthopedic spine surgeons. A great show today, Dr. Okubadejo. We'll be right back.
Newport, the luxury waterfront community on the Hudson River, offers a quality of life you deserve in 10 high-rise rental towers with amenities such as the on-site Newport Path subway, light rail and ferry service, Newport Town Square, 3 playgrounds, dog run, upscale restaurants, retail giants like Sears, JCPenney, Macy's, and Target. Morton Williams Supermarket is just outside your front door. A health and fitness club, spa, skating rink, and medical facilities are also on site. NewportNJ.com. Enjoy the New York skyline from Newport Town Square. Manhattan is just one path stop away or quick ride through the Holland Tunnel. Nursery and private elementary schools all on site. 12-screen movie theater at the Newport Center Mall. Want to visit Newport? Stay at the Westin or Marriott Hotel. Go to NewportNJ.com for details. Newport has luxurious towers, great restaurants, shopping, New York skyline views, schools, playgrounds, a marina and yacht club, gym, spa, fine wine, fine living. It's incredible. It's you. NewportNJ.com. Newport, live like you want.
Seeing the ER doctor at the Jersey City Medical Center has never been easier. If you're sick, you just click. Go to libertyhealth.org, and here's how it works. Click Skip the Wait. Select your time and check in now. Enter your symptoms, your personal information. Click Proceed to Confirmation, and the doctor's waiting for you. The Jersey City Medical Center. Make Hudson County's #1 hospital your first choice.
Welcome back. We're here with Dr. Okubadejo, who is one of our premier orthopedic spine surgeons, one of the team of orthopedic surgeons at Jersey City Medical Center. Welcome, Dr. Okubadejo. Glad you're here. Tell us a little bit about yourself.
Absolutely.
Where did you do your training, and kind of tell us a little about some of the stuff that you do.
Okay. I'll begin first with my name, actually, Okubadejo, so that's Joe Smith. So Okubadejo is a Nigerian name.
Okay.
My parents came here in the 70s. I was born in Brooklyn.
Oh, okay.
I went to Brown University for undergrad, Johns Hopkins for medical school,
Okay.
Residency at Washington University in St. Louis, and then a fellowship at the University of Pittsburgh.
Wow. I'm not sure people understand. The University of Pittsburgh is one of the premier sports medicine programs in the country, right?
Yes, it is.
Yeah. And they've got some world-renowned surgeons there, so you learned
Absolutely.
under the best, right?
I did.
That's right.
Yeah.
So we can provide that best care right here in Jersey City.
Absolutely.
That's great. So what about some of the things that you do? So I guess you deal a lot with back pain?
I do a lot with back pain. Just to reiterate the training, residency was in orthopedic surgery at Washington University in St. Louis. And that, in orthopedic surgery training, you cover the entire musculoskeletal system, including the spine.
All right.
And then during fellowship, we specifically hone in on the spine only.
Okay.
And now my practice is 100% spine surgery.
Oh, I see.
A lot of the techniques that I currently use in my practice are minimally invasive techniques.
Okay, so let me stop you there.
Yes, sir.
You talk about minimally invasive. So when people think about surgery, they think about somebody cutting them open, but that's minimally invasive means you're minimizing all that, right?
Absolutely.
So explain
minimal incision.
Yeah. So explain kind of what that means for people.
Absolutely. So this is actually a model of the spine. So the way to think of spine surgery actually is to think about what your problem is and what exactly you need done.
Okay.
So the beauty of the current way we practice medicine is that we have many new techniques to address patients' specific needs. In the past, typically, we made big incisions down the center of the spine, and we did big lumbar laminectomies.
So they would actually cut through those? Wow.
Yeah, we'd cut right down the middle of the spine and remove huge segments of bone in order to take pressure off the canal and free up the nerves.
Okay.
That's still done today. Some patients still need that.
Okay. So explain to people why they get the pain.
Okay.
They get the pain because the bone is pressing on the nerve? Is that?
Absolutely.
Okay.
Absolutely. So when we're young, our spine is absolutely perfect. This is actually a model of a perfect spine.
Right.
And we have the lumbar vertebrae, which are the bones.
Right.
In between the vertebrae, we have the discs.
Okay.
Okay. As we get older, these discs tend to change. They become a lot less spongy.
Okay.
And they tend to collapse.
Oh.
As the disc collapses, it bulges back into the nerves.
Oh.
And with that motion, these joints back here called the facet joints tend to form bone spurs. And these bone spurs also encroach the space.
Wow.
And then in addition to these two factors, you also have a tissue between the lamina called the ligamentum flavum. And that tissue thickens over time. So you have multiple factors leading to compression within the canal, and that compression is what manifests as back pain and leg pain.
Oh, I see. Okay, and that runs all the way from the bottom of your back all the way up to
Absolutely,
to
all
your
the way
neck.
from the neck all the way
So
down
that's
to the
why
back.
some people talk about they have lower back pain or neck pain,
neck pain.
whatever. Okay.
Exactly.
So before you used to go and cut that open and try to relieve that pressure, but now it's minimally invasive?
Yes, well, it depends on exactly what your diagnosis is.
Mm-hmm.
If you have multi-level problems, meaning you have problems at multiple levels in your spine at the same time,
Right.
then we still have to go midline and do
Okay.
a full decompression.
All right.
If you have a problem that's only at one level,
Okay.
say between L4 and L5,
Right.
we have techniques where we can avoid going down the middle,
Right.
and we can actually make small incisions on the side, about an inch,
Okay.
and go in directly into the disc from the side, open up that space, and then through X-ray fluoroscopy, put in screws that we need to balance everything out. If you have the most common problem that most people have is actually a disc herniation.
Right.
So, and that's when one of these discs bulges back into the nerve.
Okay.
So no longer do we have to go down the middle in order to create room. Through a little tube, typically about 18 millimeters,
Wow.
with the use of a microscope, I can get into the space, remove the herniation, protect the nerve, and you have immediate pain relief. And that's actually done outpatient.
Wow. So before people would have back surgery and they'd be in the hospital for days, and now you can do this minimally invasive and do it, and they can leave the same day?
They can leave the same day.
Wow. And what's your success rate?
I would say success for these procedures typically is about 95 to 100%.
Wow. That's really amazing.
Thank you.
Now, you don't always like jump to surgery first, right?
No.
I mean, when you evaluate somebody, tell us kind of what that process looks like. They'll come in, I got lower back pain or I
Right.
got neck pain.
Right.
What's the first thing you do?
Typically, most patients who have back pain or neck pain go to their primary care physicians.
Right.
They complain of their pain. The primary care physician has to differentiate from musculoskeletal pain to other causes of pain. Sometimes it's cardiac, pulmonary,
Right.
there could be other things, rheumatologic, that are causing that pain.
Okay.
If it truly is musculoskeletal, they treat it. Once they've reached the end of what they can do, then they refer the patient usually to a pain specialist.
Right.
The pain specialist does other things, and when they fail that, then they end up coming to me, and then I devise a surgical way to get them better.
Okay. So someone could have back pain and it may not be their spine. It might be a muscle spasm or something like that.
Absolutely.
And so that pain specialist tries to kind of figure that out.
Yes.
Now, do you always just send everybody to surgery, everybody who comes to you?
No.
Okay.
I have some patients who come to me directly without seeing any other doctor.
Right.
Once I make the diagnosis, then I determine what they've had done.
Mm-hmm.
If they have not had conservative care, meaning medications or injections,
Right.
then I send them to someone who makes that happen.
Okay.
And once they fail that, then they come back and I perform surgery.
Oh, I see. Okay. So on the spine, so when you talk about some of these spine techniques and the things that you do, everybody's done on an outpatient basis now? That's
I wouldn't say everyone. It depends
Okay.
on exactly what your diagnosis
Right.
is. If you have a single disc herniation,
Right.
that can be done outpatient.
Okay.
If you have a single level problem, even fusions can be done outpatient for one level. But the more complicated your diagnosis is, the more time you spend in the hospital.
okay. So when you talk about a fusion,
Yes, sir.
you talked about putting the screws in, and you do that minimally invasive.
Yes.
So there's really very little incision. Do those screws actually hold what you're trying to do in place? Is that it kind of replaces what the structure is that's in your spine?
Typically, in order to decompress the spine, we have to remove certain structures.
Okay.
The goal of spine surgery is to take pressure off the nerves.
Right.
We have to remove interfering structures in order to get there.
Right.
I'll give you an example. When I do a minimally invasive lumbar fusion,
Right.
I make an incision slightly off the midline. I remove this bone called the facet joint.
Okay.
And then I get into the disc and I do my work on the disc to decompress the nerves.
Right.
Once that's done, now you've lost a segment of your bone.
Okay.
So I need something to stabilize that region since I've done something else in order to get to your nerves.
Right.
And that's where the fusion comes in, where we put screws and rods just to hold things together until
Right.
it heals.
That's really fascinating. We're going to be talking more about some of the things that you do, and we'll be right back.
Jersey City Medical Center, Hudson County's #1 hospital, as ranked by U.S. News and World Report. Hudson County's only hospital to receive an A safety score rating. Jersey City Medical Center is Hudson County's only hospital to receive the prestigious Magnet Award for Nursing Excellence. Make the #1 hospital in Hudson County your first choice for quality health care. Jersey City Medical Center. Visit us on the web at libertyhealth.org. Jersey City Medical Center, Hudson County's #1 hospital, as ranked by the U.S. News and World Report. Why? Because of its patient care, not its bottom line. Jersey City Medical Center, for patients, not for profit. The Jersey City Medical Center accepts all patients and most insurance. At the Jersey City Medical Center, your health is our concern, not our bottom line. Make Hudson County's #1 hospital your first choice. The Jersey City Medical Center, for patients, not for profit. Visit us on the web at libertyhealth.org.
We're back with Dr. Okubadejo, one of our premier orthopedic spine surgeons at Jersey City Medical Center. Dr. Okubadejo, you know, I was just thinking, we had a patient who actually did a testimonial for us. Excruciating pain. He said he couldn't move, you know, was really concerned about how even his lifestyle, had a young baby and, you know, felt really, really bad about that. And he said, you performed like a miracle. Like, as soon as the surgery was over, it was like phenomenal that the work that you had done. Is that typical? What happens with people in that much pain from these kinds of problems that they have?
Absolutely. When you have pressure on a nerve, that nerve pain is constant and searing. It affects quality of life significantly. People can't sleep, they can't work, they can't travel. They're incredibly unhappy.
Right.
And once the diagnosis is made and the pressure is relieved, the happiness that they tend to experience is quite dramatic.
Oh, yeah, this guy was he was like, this is life-changing for me.
Absolutely.
So people, the key is people really shouldn't put up with back pain. There are solutions to that.
Yes, there should be no fear.
Right.
Once you have the pain,
right,
have a diagnosis,
right,
and with the new techniques, we'll get you better immediately.
Wow. So we talked a little bit about lower back pain. Now, what about people with their neck? Isn't that a little more tricky to kind of treat? Are there issues that are different than lower back pain than for example, neck pain?
Yeah. The best way to think about the spine is divided into two segments. There are two segments that have motion. You have the cervical spine, which is the neck.
Right.
In between, you have the thoracic spine, which is stiffer.
Okay.
And then you have the lower back, the lumbar spine.
I see.
Most pain typically is in the cervical spine, in the neck, or in the lower back.
Right.
People have a fear of neck surgery if they have neck pain. And what I try to do is to demystify the spine and explain why they should really have no fear.
Okay.
The most common procedure I do in the neck is called the anterior cervical discectomy infusion.
Okay, so explain kind of, is that from the bottom of your skull down?
So
is that what that is?
This is a model of the neck.
Okay.
This is the skull.
Okay.
This is the front, and this is the back.
All right.
So this is the back of the neck. Most of the time that people have herniations within the neck, one of these discs, which are between the vertebrae, that's the white.
Right.
The disc is the gray. The disc bulges back and impinges upon either a nerve or the spinal cord itself. This is the spinal cord in the middle.
All right.
Most procedures that we do to take that pressure off take place in the front of the spine.
Oh.
Okay? Now, everyone worries about the spinal cord and can the spinal cord get injured.
Right.
And that almost never happens. I've done hundreds of operations and that doesn't happen. Why is it so safe? When we go into the spine, we're going layer by layer under microscopy, and we're working in front of the spinal cord.
So when you say microscopy, you're actually looking at a microscope that's kind of enlarging things for you?
Yeah, I'm working under a microscope.
Right.
And this enlarges this entire field, so everything's very magnified.
Right.
And the lighting is ideal. And I'm working layer by layer by layer, removing the disc from the nerve and the spinal cord. And now I have a space that's created once that discectomy, it's called a discectomy.
Right.
Once that discectomy is completed, now I have a space. And
so
I fill
you
that space.
can tell from looking at this microscope when you're even getting close to where the spinal cord.
I can tell everything.
Really?
Everything, yeah.
Wow.
Yeah.
Is that minimally invasive also?
It's minimally invasive in the sense of the type of incision that's done.
Right.
But the decompression.
But you might have a small incision?
The incision's smaller.
Right.
However, what I visualize is normal. I see everything that I need to see.
Okay.
Yeah.
And you do that through the front?
I do that through the front of the neck.
Wow.
Yes.
Wow, that's really amazing. Yeah. And what's your success rate? What do people, they have that kind of really bad neck pain?
Yeah. I would say for neck surgery, success rate is even higher than back.
Wow.
Because we're going through less muscle in order to get to the neck. I'd say it's probably 97% to 100%.
Okay.
Yeah.
Wow, that's fascinating. How do you learn to do that?
Training.
Yeah.
You have to be very well trained.
Right.
I've been fortunate to have been trained by the best.
Right.
So at Washington University in St. Louis, at University of Pittsburgh, I had the best instructors.
Yeah.
And of course, practice, once you begin practice, and taking courses to update your skills and to know what's out there.
Right.
And I've been in practice now 5 going on 6 years.
Right.
So I'd say I'm in my prime.
Right.
A wealth of experience and a wealth of technical skill.
Now your office at the medical center is right there on Grand Street?
Right on Grand,
Okay.
333 Grand Street.
Okay, right across from the
next to
brownstone,
right?
right?
Next to the brownstone.
There you go,
And right
okay.
next to the medical center.
Right, okay.
Absolutely.
And you're there pretty much every week? You're at the medical...
That is my main location for my
Okay.
practice. Every single
right.
week you can find me there.
Okay, great. Now, you also work very closely with some pain management doctors.
Yes.
Right? And you guys refer back and forth to each other
Yes.
based upon what the need is.
Absolutely.
So somebody might come into you and you might say, you know what, I'd like really for you to see the pain management doctor before I do anything this invasive, right?
Absolutely.
And what are some of the ways people can prevent this stuff from happening? I mean, are there things that you kind of recommend to people, exercises, stuff like that?
Yes. The key to maximizing your back health is core strength.
Okay.
So we always encourage people to be active in the gym,
Right.
to do exercises that focus on their abdomen
Right.
and also their lower back.
Okay.
The biggest key actually is weight. So your BMI, that we have formulations for BMI.
So
Typically,
tell everybody what BMI is.
body mass index.
Okay.
And it's determined from your weight and your height.
All right.
And typically, a good BMI should be between 26 to 30.
Okay.
And for every extra pound that your body has, your spine actually sees it as 3 pounds.
Wow.
So it's important to be within a decent range to
Right.
minimize your back pain.
Okay. Are there specific exercises, like if somebody comes to you and you say, you know what, I know you've got some pain, but, you know, especially for young people, there's some exercises that you encourage them to do before you would, you know, even go through any kind of surgery or anything?
Right. It depends on what you're presenting with.
Right.
If it's more back pain without having a true structural cause of your pain,
Right.
then I encourage them to adopt an aerobic type of a regimen initially,
Okay.
which can be running, cycling,
Right.
using the elliptical. Things in water are actually outstanding
Okay.
because water tends to negate gravity.
Right.
And swimming and any water activity usually is good.
Right.
And then abdominal activities. You can do sit-ups, you can do leg raises, planks.
Right.
Planks are an excellent way to develop the core musculature.
Right. Now, are there people that, let's just say somebody comes in and they say, you know what, I really want some help in understanding what those core exercises are. Are there physical therapists that you guys work with?
Absolutely, absolutely. We call our spine institute a comprehensive institute, meaning we have team members who can address every aspect of the spine.
All right.
I am at the end of the line when it comes to surgery.
Okay.
But we like our patients to exhaust the other doctors who are available.
Right.
So our therapists, our pain specialists, they go through every mode of treatment, which is conservative care,
Right.
before they end up coming to me for surgery or needing surgery from me.
Sure. We talked about lower back pain and then neck pain. What percentage of the population will get to the point where they actually need surgery?
That's an excellent question. I would say who need surgery, typically at perhaps 10 to 15% of the population.
Okay.
The majority of the people that I see don't need surgery.
Right.
And I think many people are often afraid
Right.
to see me because they think the first thing I'll mention is surgery.
Right.
And that's typically not the case.
Right.
My goal is to educate you.
Right.
I have models. I'm very detailed with going through MRIs so you understand your body and why
Right.
you have the pain.
Right.
And I give you options as to what you need.
Okay.
So if I'm telling you need surgery, then you're falling within a small percentage of people who do need surgery.
Okay.
And typically that means I'll get you better.
So that's really your last resort.
Absolutely.
I mean, you really want to try every other modality before you send them to surgery.
Yes.
Which I think is a good way to go. I mean, once people have back surgery, you know, they understand how serious it is.
Absolutely.
And so you want to make sure that that's your last treatment option.
Right. And if you do end up needing surgery,
Right.
It's very straightforward. So
Right.
don't see it as a dire sentence.
Right.
It's actually an opportunity to be pain-free and live an excellent life.
Great. We'll be right back.
It takes more than a state-of-the-art medical facility to make a great hospital. It takes a team of dedicated medical professionals. That's the Jersey City Medical Center, Hudson County's #1 hospital. Medical teams consisting of New Jersey's top doctors, Magnet Award-winning nurses, and accomplished hospital associates, all committed to your good health. That's what you have at the Jersey City Medical Center. Make Hudson County's #1 hospital your first choice. The Jersey City Medical Center. On the web at libertyhealth.org.
Panapinto Properties, Jersey City. Shaping the workplace with state-of-the-art office space and an address your company desires. Building residences that define your home environment. Adjacent to all modes of transportation. On-site parking available. The right address, the right lease. 201-521-9000 or visit on the web at panapintoproperties.com. Panapinto Properties, building Jersey City for everyone.
We're back with Dr. Okubadejo talking about the spine and the back and how we treat a lot of that. Now, Dr. Okubadejo, there are times when people absolutely have to come see you.
Absolutely.
Tell us a little bit about some of the things that you're concerned about when people absolutely need your services. What are some of the things that they might come to you
Most
for?
people who have spine problems typically have elective problems,
Right.
Because it's pain related. This becomes more dire when it's a functional issue.
Okay.
As we mentioned before, in the two segments of the spine, the cervical spine, the neck, and the lumbar spine, there are two scenarios where I'm most concerned.
Okay.
In the cervical spine, we'll go back to our model once again.
Right.
When you have compression directly of the spinal cord,
Right.
that can manifest as having issues with balance, having problems with handwriting,
Okay.
having bowel and bladder issues, and that's called a cervical myelopathy.
Okay, so that's when the actual cord is involved, not
Yes.
just those nerves that are coming out, but the
Exactly.
actual inner core,
The
your
cord,
spinal,
the cord itself,
spinal
yeah.
cord. Right. Wow.
So, because when you have a disc that's herniated and it herniates backwards,
Right.
it can either herniate towards a side where it affects a nerve and that
Right.
causes arm pain, or it can go directly back where it impinges on the spinal cord,
Okay.
and you have signs of spinal cord injury.
Right.
That tends to be irreversible if it's left for too long. So, if you have any concerns at all, where you're having difficulty walking in conjunction with your neck pain,
Okay.
or you feel very clumsy, or you have bowel and bladder issues,
Right.
then that's more of an emergency.
Wow.
And you have to see your spine surgeon as soon as you can in order to have the diagnosis and have the treatment.
And then how do you treat that?
It depends on how many segments are involved.
Right.
If it's just one or two discs, then just as we do for arm pain,
Right.
we do an anterior cervical discectomy infusion where we go from the front of the spine and remove the disc layer by layer
Okay.
to decompress the spinal cord.
And again, you're using that microscope
With
and
the microscope.
you're being very careful
Very
not
carefully.
to touch the spinal cord.
Exactly.
Right?
We're working in front of the spinal cord.
Right.
So we're removing things from the front of the spinal cord
Okay.
in order to decompress the spinal cord.
Right.
And that relieves what the problem is.
Why would they have like bladder symptoms when it's up in your neck? I mean,
Right.
what's the connection?
The spinal cord connects from the neck all the way down
Right.
to your lumbar spine, and those nerves control everything going down.
Oh, I see.
Yes. So any problem, as we call upstream,
Right.
can affect everything downstream.
Okay.
So in the most severe situations, most dire situations, you can have dysfunction that affects everything below the neck.
Wow. And then once you kind of relieve that problem, then those symptoms go away for the most part?
It depends on how long you've had the problems for.
Right.
So if you've had problems for a long time, then
Right.
it takes longer for recovery. Unfortunately, in some patients, some symptoms are permanent.
Right.
That's why it's critical to see your spine surgeon as soon as you have those worries
Right.
in order to differentiate where you are.
Okay.
Just to mention another scenario.
Sure.
Some older patients over time develop what we call cervical stenosis,
Okay.
where the entire canal tightens up. And we can't just go from the front of the spine. We actually go from the back of the spine.
Okay.
And we do what's called a laminectomy.
All right.
Because it's so many levels.
Right.
So we actually remove these bones
Right.
from the back of the spine, and that takes the pressure off the spinal cord.
Okay.
And then we stabilize it with screws on the side, which we call lateral mass screws. So we do a laminectomy and
Okay.
a fusion, and that solves the problem as well.
What are the symptoms that people would have? Is that just neck pain, or do they have
You
the
have
same
neck
kind?
pain, you have problems with balance,
Okay.
you have clumsiness,
All right.
you may have tingling in your hands.
Right.
You just have what we call, you could have spasticity.
Okay.
Those are signs of spinal cord dysfunction.
Right.
And that's in the cervical spine. But there are also problems in the lumbar spine that are very concerning as well.
Okay.
So I'll shift over to that.
Sure.
So in the lumbar spine, there's a scenario called cauda equina syndrome.
Okay.
So the cauda equina begins below about, each of these is numbered. So below about L1 and L2,
All right.
you get into the cauda equina.
Okay.
If you have a huge disc that impinges on the spinal cord and blocks everything off, then you have dysfunction of everything below that.
So when you say you have a huge disc, you mean you have a compression of the disc?
You have
Is that-
compression, exactly.
Okay.
So as we discussed, we have the vertebrae,
Right.
and we have the disc between the
Right.
vertebrae, and in some scenarios, the disc can protrude backwards into the nerve and into the entire